I figured it out. Good morning, committee members. How are you today? Good.
Good morning.
Good. So I will start the meeting. The Board of Direct Entry, Midwifery, Legend, Drugs and Devices Continuing Education Committee meeting is convening at 10:05 a.m. on October 6, 2022 at the Health Licensing Office in Salem, Oregon by telephone conference call. I will now call roll. Holly Scholas, absent. Colleen Forbes. I think you're on mute, Colleen.
I'm here.
Julia Bailey. Greg Ramirez. Greg, are you still with us? Oops, I think you're on mute. I still can't hear you, Greg. Do I need a verbal from him, April, or can he just raise his hand and I acknowledge that he's here? Okay, so Greg is raising his hand in acknowledgement that he's here. Desi Lang.
Here.
Catherine Akerson Bailey.
I'm here.
And Haley Beeson. I believe she is absent. If she joins, we'll recognize her when she comes in. Members, when you wish to speak, please state your last name for the record. Committee members are asked to not use the chat feature during the meetings. Public members wishing to speak must first sign in on the roster sheet available. For public members calling in on the public phone line, I think that was Greg that was exiting. Let's start now. For public members calling in on the public phone line, please email April Fleming at april.fleming@dhsoha.state.or.us and provide your first and last name. Public and interested parties' feedback may be heard during the public interested parties' feedback period if indicated on the agenda. Everyone is asked to use appropriate language, manners, and protocol when conducting board business, and this meeting is called to order. Did everyone get the revised document that I sent them this morning?
Yeah.
Okay.
Yeah.
Perfect. So on the agenda, we'll just go over that. We did the call to order. We're gonna do an update from the August 30th, 2022 LD&D CE meeting that we held. We will be talking about TXA. There was a Rules Advisory Committee meeting that was held, and also the board listened to the recommendations from the Rules Advisory Committee, and they have tasked this committee with putting together an FAQ in addition to a Rules Advisory Committee member. They've moved that up to a priority for this committee. We'll be talking about the standardized competencies. We'll go over the skills examination. I don't think we're going to get to the written examination. I'm almost positive we won't be getting to that. And then we'll talk about our next steps. So at the August 30th, 2022 LD&D CE meeting, we went over the standardized competencies. We got a lot done on that. We got all the way up to suturing. And I actually took it upon myself to send those to Colleen and said, hey, Colleen, do you think you could take a look at these? So thank you for doing that, Colleen.
Yeah. They're really kind of half-baked because I didn't have time.
That's okay. You know what? I appreciate your willingness to even look at those. And we'll go over
meeting early. That's what happens when you leave a meeting early, is you get handed stuff that you don't want.
Actually, that was me. It was all me. I'm going to take all of it, Colleen. It's like, oh, we didn't get that done. Maybe Colleen has time to look at that. So, I got all of the to-dos back from everyone. So the document that we are going to be looking at today, I left the old language, added the new language. I did a color coding chart. That way I wasn't sure if I was supposed to leave some of it, and I just thought if I left it all and added the new, we could determine and then just go through each one. So we'll be doing that. So I'm going to start off with the TXA in regards to the Rules Advisory Committee. So during the Rules Advisory Committee, it was discussed that, and they made a recommendation to the board, that TXA needed to be added to the competencies and the skills and written examination. And in addition to that, they recommended that this committee put together a separate training program, and that would be maybe 1 to 2 hours. And then, so that went to the board, and the board decided that that is not how they wanted to proceed. And the board recommended that we put an FAQ together. So one of the things we'll be doing, and I had emailed you this, is that one member from this committee and one member from the Rules Advisory Committee will work with Sammy and I to put together an FAQ. And so if somebody wants, and we can talk about this a little bit further, if somebody wants to volunteer, and we can kind of talk about criteria and such. But in addition, we will be adding it. So when we're going through the competencies, we will have to identify where that needs to be added. And then also when we do the skills and the written examination, just to make sure that, that TXA is covered in how we're doing the standardized competencies and the exams. So, in regards to TXA, one of the things that I have noticed, in talking to the RAC members and sitting at the board meeting, is that some people don't have experience in TXA. And one of the things that I had talked with Sammy about is maybe that's actually a good thing if somebody doesn't have that experience, because maybe then putting the FAQ together is going to be important as to what they need to learn or what's important to somebody who doesn't know the information per se. But or maybe it's better if somebody actually has the experience, and that way all the competent information can be put into that FAQ, or maybe one of each, somebody who does and somebody who doesn't. So I have called the committee members on the RAC. I haven't heard anything back from them, so I haven't gotten a volunteer from that committee. So I don't necessarily know if that individual will have experience or not. And then I have to have somebody willing to do so. So what are your thoughts on that? And was that clear enough? Do you think that it should, so I'm just going to ask this, do you think that one committee or both committee members should have experience with the TXA, or one committee member with experience and one committee member without?
I like that idea, Cynthia, and because I think somebody with experience it's going to be really important, but somebody without it is going to be able to identify the questions that most midwives who are using it for the first time will have. And so that seems like that would really tap into that community that doesn't have any experience at all a little bit better. Like less assumptions, fewer assumptions.
Okay. And then the other thing is that the board had stated is that these recommendations from the FAQ will be discussed at this committee level, and then we will put that forward to the RAC. So it doesn't have to go back before the board before going to the RAC. So is there somebody that from this committee that has experience with TXA? Because I believe in looking at the list and talking with Sammy that the individuals, and I this is just my understanding, they don't have the TXA experience. Is there anybody from this committee that has the TXA experience that would like to volunteer for the FAQ?
That's not me.
I'm happy to help. I have administered it before at a birth I was assisting in Washington under the supervision of a midwife there. But I wouldn't call that really experience. It was one time. So,
Is there
but I'm
anybody
happy
else?
to.
Oops, go ahead,
Yeah.
sorry.
I'm just saying I'm happy to help with that.
Okay. Is there anybody else on this committee that has extensive experience with the TXA? No? Okay, so if everyone's okay with that, Desi, thank you for volunteering, and we'll just move forward with and see where we fall within the other committee. And even if no one on either committee has experience, we'll figure it out and put it together and move it forward. We
Sorry,
can
I
do
missed
this.
that last piece. I was on a quick phone call. I apologize.
Oh, no, that's okay. Catherine, do you have any experience with TXA?
I have never used it, no.
Okay. So Desi has volunteered to work on the committee, the specialized committee for TXA, and there will be one individual from this and then one individual from the Rules Advisory Committee. And our goal is to have one person with experience and one potentially without. But we'll see what happens with the RAC committee, and we'll just move forward and we'll make it happen. We'll figure it out and get all the information, do the research, and get it down on paper, and it'll go through this committee, and then it'll go through the Rules Advisory Committee, and then it will go before the board.
I don't know if you're needing like a licensed midwife who has experience. I know of a couple who worked in different states where they had access to it and could give some names if you're needing that for that committee.
You know, one of the things is the board had said that we could have a member from each of these committees, but maybe if each of you individually could email me with some names of individuals that you know of that has some expertise in that or a lot of experience, that would be very helpful, because it is a specialized committee and we can always pull somebody else in. Okay. So we'll move forward with that. So then we'll go right on to the competencies. I'm going to share my screen so we can all look at the document that I sent you this morning. Can you guys see the document?
Yes.
Okay, very good. I'm going to try to get rid of that and make it bigger. So like I had stated before, we pretty much went through everything except for suturing, and then Colleen was able to provide me some information on that. So anything that does not have the coloring, we were good with. So this first one was provided, and everything was exactly the same except adding typical to the unit. I need to bring you guys up so I can see your faces. Okay.
Yeah, to be honest, when I was looking at this, I have no idea. I don't remember what it was we were going for, because what I remember is I talked about what we usually do in class, where we identify like how a drug in particular, like, Methergin usually is is in a glass ampule. So like assigning like the typical dose and packaging for each medication, I think was what we were talking about.
Yeah, I mean, it's not, I don't know that it should say typical dose. Like we have a specific dose that's in our formulary, right? That maybe those should be two separate things, like the dose of medication that we're allowed to give and the typical packaging it comes in.
Yeah, typical packaging and unit dose. That makes sense. I mean, we have dosage guidelines already, so maybe we should just take dose out, like typical unit packaging, because then next we have dosage guidelines. So I don't think it would be repetitive. I don't think we need that in both places.
I
I mean,
agree with
there's also a section later on about different kinds of packaging.
Yeah. Yes. So much packaging.
Okay, so change it to the typical unit packaging and take out the unit dose, and then the rest of them, everything else is fine with the mechanism, the onset, the peak, the therapeutic, duration, side effects, everything is good with the rest of them.
Yes.
Okay, so we'll go down to, we really did a great job on our August 30th meeting. We got a lot done. Okay, so
Can
describe.
you go back to 1.5 for 1 second? I just looked through this last night and was noticing I'm confused about why. So 1.5 says explain the mechanism of action for each of these baby meds, but it seems to me like instead of this being a separate 1.5, that these two baby meds, 151 and 152, should just be in the above list, because we don't only want the mechanism of action for these two meds, we want all of the above listed items for these meds also.
So was this, I think we added this for the neonate.
I know, but what this format is it's saying like in 1.4, we want to know all of this long list of things for all of this list of adult meds. And then it says we only want one of these items, the mechanism of action for these baby meds. We actually want all of these things for the adult and baby meds.
Okay.
Yes, that's correct.
Yeah.
So
My
taking,
recommendation would be to just get rid of 1.5 and move the list of baby meds to 1.4 at the bottom.
Yeah,
I
I
don't
think
know what the numbering would be. 1.412, 1.413.
perfect. I see exactly what you're saying. Sorry.
Yeah, exactly. They just need to be added to that long list of meds there to know all of those things for each of them. I know it messes up all the numbering again.
That it's going to be messed up anyway, believe me. Okay, perfect. So
And then this is so nitpicky, but 1.5.1, it says eye prophylaxis for disease of the newborn. We don't actually give it for disease. We just give it for prophylaxis. So it should just say eye prophylaxis.
for the newborn,
Sure.
or just take out for the newborn.
Either way is fine.
Okay. If I'm moving it up above, let's take, my suggestion is to take out for the whole thing right there.
Okay.
Is that okay?
It's fine.
Anybody else?
Yeah,
Any-
sounds
fine to me.
Okay. Okay, so then we'll go down to 1.7, and Holly isn't here, but
Did she send this to you?
yeah, yes.
Yeah, it looks good to me too.
So we'll just move forward with taking this out and then leaving that. And then we'll go down to, and formatting is really ugly because when you add a bunch of stuff in there, it just starts. And because we're going to be taking stuff out and moving stuff around, I didn't format it because it'll have to be done again. So, this was 1.24 routes of administration. So this was, new language that was, provided to me by Desi. And there wasn't anything there before. Okay. Greg, is that you again? Are you joining?
That's me again. Is it working
Oh.
this time?
Yes, we can hear you. Thank you.
Oh, thank goodness. Thank you very much.
Yeah, I think this looks great, Desi, for 124 to me.
Okay. So we'll go ahead and move on past that.
The only,
Uh,
so when under 1.24, she lists the angle of entry for sub-Q and intradermal, but not for intramuscular. So we could add it a 90-degree angle for the IM and injection. I don't know how important that is, but it would stick with the formatting that we have.
into the muscle at a 90-degree angle.
Yeah.
Administered using a needle directly into the muscle, yeah, at a 90-degree angle.
I'm just gonna type degree because I don't know where it is on my, the little circle is on my, but I'll fix that.
Just copy it and paste it from the other
Oh,
ones.
there you go. There we go.
I had to do that already.
And
Plan.
I just had like 3 more really brief questions about something above here, and I don't know if there's time for that. I know I apologize for missing last time, but
No,
I-
absolutely, there's time.
okay. Under 153,
Oops.
1.5.3. Sorry, the numbering is confusing. I just was confused about this list of aquamaphyton and conocyon. The vials that I usually get just say vitamin K1, and I don't know if we should, like, I think these are brand names. And I don't know if it matters, but vitamin K1 could also just be on this list. Or
So do you want me to take off the aquamaphyton and the conocin and just say vitamin K, what you stated?
I would maybe just add it if that seems appropriate, so that all of those are an option depending on what we're able to get at different times.
Or having it just say vitamin K1 with like the brand names in parentheses as examples of the type of vitamin K1 instead of another
Yeah.
Yeah,
numbered point.
like including aquamaphyton and conocyon or whatever. Yeah. So there would just be one instead of a list of 3.
Yeah.
And I
like
think the
that.
drug name itself is like phytodione.
I don't
probably,
know. I don't know.
Yeah.
It's true. That might even be better, Julia, to actually just call it that, to call it phytonadione / vitamin K1, including these brand names.
Yeah.
Could you say that again, please?
phytonadione / vitamin K1.
And-
Yeah.
N-A.
DIONE. Yeah.
And then do vitamin K
Great.
and say including.
Perfect.
Is that okay?
Yeah.
That looks
I like
good.
it better.
Yes.
Okay. And then this will be 1.
Yeah, perfect.
Okay.
And then 1.6, I was just thinking the rewording, it says describe the signs and symptoms of an adverse reaction to a pharmacological agent. And the answer is what an adverse reaction is, not the signs and symptoms of an adverse reaction. So I think this should just say define adverse reaction to a pharmacological agent.
Yeah, because the list of signs and symptoms could get real long.
So you can just delete describe the signs and symptoms of. Yeah.
Okay.
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 Okay. And then does it go, how does the numbering go? I have 1.20 listed after these things. Does that make sense? No.
So 1.20 is going to be down here.
Yeah.
Explain how an interaction may result in an increase in the length of labor. Is that what you're looking at?
Oh, Yeah, I just didn't understand what we were trying to get at there, but maybe that's fine. Explain how a drug interaction may result in an increase in the length of labor. Yeah, I don't.
Does it need to be changed? Is it confusing?
Yeah.
I'm
Does
not,
anyone else know what that
I'm
means?
not sure exactly what we're going for there either.
I don't know.
We're getting close to consensus on ditching it.
Right?
Yeah, I feel, yeah, it seems unclear to me. I would just delete it.
Okay,
Well, and the answers don't seem to make sense either.
Yeah, agreed.
okay. So we'll
And
just take that off if everybody,
I think it's fine. Yeah,
okay.
I'm almost done.
No,
Thanks.
no, you're fine. This is good. We need, every set of eyes that we can, we went over a lot of information at our last meeting. And so,
Yeah.
a fresh set of eyes of what was
Fresh
done
eyes.
is good.
Yeah, 1.30, I just wanted to say, might have just been a route with an E. 1.34, let's see. What was this? Explain requirements for tracking drugs and devices. Can you go to the bottom of this one?
Uh-huh.
Oh yeah, it says expired, deteriorated, or unused legend drugs must be disposed of in a manner that protects the LDM. I think this is just supposed to be a comma instead of a period here. LDM, comma, client and others. It's just one sentence. And then in 2.1, I don't know if we're there yet or not.
We'll go back up because we stopped at one of the ones that had been changed. So we'll
Okay.
go through your list. Okay.
2.1, a set of strategies developed to prevent the transmission of bloodborne pathogens instead of. Okay, I think that was it for now.
Okay, well, if you think of anything else as we go through,
Okay, thank
we
you.
will add it, change it, delete it. So let's go back up to, we were at, let's see. That was Desi's, we did that one. Let me go back. Find where we were. Hang on, I just want to make sure we didn't miss anything, you guys. Let me just do a quick scan here.
The next one I see is 1.37.
So the new language, and then we'll just delete the old language.
Yeah, we had already talked about packaging earlier, like when they're going through each individual thing, each individual drug. So when we talked about appropriate labeling, I think our consensus was like if we had removed it, like put pit in a bag of fluid or something like that. Yeah, right?
Yep, that's what we were talking about.
So does the intro need to be changed at all?
I would say describe appropriate labeling for legend drugs and devices, or we can take packaging out because this doesn't talk about packaging at all, and we already have them talking about packaging.
Right. Can we say describe the appropriate labeling for legend drugs once removed from their original packaging?
Yes, I think that sounds great.
Sorry about the font. Don't know what's happening there. Describe the appropriate labeling for legend drugs and
Drugs
devices.
once
Oh.
removed from original packaging.
Yeah.
All right. 1.38, explain the drug reference, what a drug reference is, and then we have the new language, taking out the old language. Pretty
Mhm.
good. Okay. We just took out 1.39, moving down to 2.3, list equipment needed for medication administration based on the route of administration.
Yeah, I don't even think you need that, but whatever.
Looks good.
Mhm.
Move on. This 2.4, I had some questions. Explain the different needle sizes, length, and bore needed for medication administration. And then when discussing needles, differential between straight needle, butterfly needles, and IV catheter needles, should this be a statement in 2.4 and replace what is already there instead of explain the different needle sizes?
Well, it does depend on the route of administration,
Mhm.
because like I've gone on to say, I went ahead and addressed both. If it's a straight needle, it's going to be, the sizes are different than catheter over needle sizes.
So go ahead and leave it just like it is for when discussing needles.
Well, is this whole section about meds by administration, or is it about meds by administration, like meds by injection and IVs? Like if it's just about meds by by injection, I think what it's actually looking for is something more specific, which is just like for IM injections of Pitocin, Methergin, and blah, 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 we use this size needle. For a newborn, we use this size needle, which I think is also somewhere lower down that Desi wrote out.
Yeah, I
And I
think
think
just this straight
that's-
needle part is what we're going for. Because I think we'll cover IV catheters and stuff when we talk about IV skills. It should be included there. So I think if we
I
take
think
out all of this top chunk.
I think you're right, but what got me off skew was when we referred to needle size, we used 18 to 22 gauge, which are catheter over needle sizes. They're not straight needle sizes.
Huh.
Does that make sense?
Uh-huh.
The catheter. Mhm.
The 18 to 22 gauge needle was literally something that was found on the web. So
Okay,
it
again-
was just to put information in there. It was based on my research, which I have no idea, obviously. I'm
Yeah,
just,
that's an IV catheter size.
Yeah.
so how would you like this to read?
Explain the different needle sizes and length and bore required for IM or sub-Q medication administration. That would narrow it down, telling me that I'm speaking to only straight needles and not
Yeah.
IV catheter needles.
Mhm.
Yeah.
I could email you something to put for this one.
Okay. Okay, so we will just. Okay, so going down to, there was no, Holly was gonna send a correct definition, but there was no change in this. So if everybody's okay with that, we'll just leave it as is,
Mm-hmm.
okay? And then going down to 2.6.
Yeah, again, this one I think is more kind of related to the 2.4, like, that we're looking for, well, I guess, I mean, it does say syringe selection should be based on the amount of medication to be delivered down at the bottom one. Like, you know, it's wanting us to make sure that we're using a 3 cc syringe, like more bigger than a 1 cc syringe when we need to give at least 1 cc of medication, and using a 1 cc syringe when we need to give less than 1 cc of medication, so we make sure we're giving an accurate amount.
Right, that's what I was thinking.
Yeah.
But then it did go on to talk about different lock sizes, and to me, lock sizes are like IV tubing. They're all kind of an industry common size. So is there something I'm missing about saline lock sizes?
No.
I think and locks should be deleted here.
Yeah.
Okay.
Yeah.
And then, so I'll take this out
Yeah.
and then the rest of it, oh, and then I guess I had a question, should this be deleted in 2.6? Or is it good as it is?
Well, I guess I'm just confused. I saw this wording where it says like the person being evaluated should be able to, we don't do that anywhere else.
Anything else? Yeah.
It's usually just a list of competencies. So I think we should
Mhm.
delete that language and just say articulate the factors involved in.
So I'll work on this language and then, so when we meet next, then I'll have some new language in there.
Okay.
Is that okay?
Yeah.
Yeah.
Perfect.
And then deleting the third bullet point because we're not talking about locks.
Yeah.
Okay. So 2.7, deleting the first part of it and just, adding the new, I don't think it goes down. Nope, that's. Everybody good with that?
Yeah.
Yeah.
Mm-hmm.
Okay. Going down to 2.8, oops. Deleting the old, adding the new.
Yeah. This was way more detail than anyone needed.
Okay.
Wait,
Because I
what?
usually
Oh, yeah.
what we're usually going for is what medications come in which types of containers.
So we combined 2.8 and 2.9. And we just deleted everything out of 2.9 and then
Moved it.
to
Right.
2.8.
I mean,
So
we
that-
could certainly keep, so in 2.9, like where it says the multi-dose vials, that, you know, where it gives like the definition of a glass ampule, a multi-dose container, and a single dose vial, like we could keep those if we want to. I don't know how other people
Well,
feel. But
that is part of 2.8. So that is what you had added to 2.8.
uh-huh.
So your lead in, and then everything in yellow's gone and the green is the new. And then 2.9, everything is gone.
Yeah, I think what Julia's saying is we could just add in the definitions of those different types from 2.9 into 2.8.
Right, we could move it up. So like in 2.9, it says glass ampules, packaging, injection drugs. Like we could put, you know, glass ampule, you know, single use packaging for injectable drugs, multi-dose containers, and then we could move like the definition from 2.9 up into 2.8.
So Julia, can you and I work on that a little bit more?
Definitely. I mean, I can, yes, for sure.
Okay. Okay. that. Okay, so, since we didn't have any information before, and so Desi provided us with new information for the, adult and newborn.
That looks good.
Mm-hmm.
I guess. Yeah, okay. It's a little bit confusing because it says just at the top, differentiate the site and equipment for. I'm imagining this is probably just trying to get the site, not the equipment, because you already described all of the equipment earlier, and I think you're going to describe the process later.
Mm-hmm.
So just take out equipment in the lead-in?
Yeah, and I think the second bullet point under adult and newborn probably needs to go further down, because what we're at here is just the site. Does that make sense?
So not in 2.10 at all?
Right, because I think further down,
It gets into the skills, and I think Desi already did like a really detailed job later on, didn't you, Desi, about how to do each of the injections?
I think I might have even just copied and pasted this into the further down section and was planning to ask about it. But it's been a couple weeks since I looked at it and I don't remember.
yeah, if we scroll down, 2.15 says list the steps for administering drug IM. So like that is where our second.
Yeah. So
I can just delete that.
Yep.
Okay. Okay.
And under newborn too. That second bullet point, because it's same procedure.
Okay.
Administration side. So 2.11 is asking the same question.
So this just needs to just be gone.
Yeah.
Okay. So this is where I wasn't sure if I should delete these bullets, these first 4 bullets, and just leave the 2. The rest of everything new? Just delete the old bullets, correct, Colleen? Yeah, okay.
Yeah, that's what I think.
Okay. Perfect. I will do that. Oopsie. Okay. So describe the 3-point check technique. Same thing. I wasn't yeah, that's a repeat dosage. Okay. Yeah, that goes away. So just the 3.
Mm-hmm.
Okay. And then
3 times.
yep, just delete the first 3 and the last 3 are new.
Mm-hmm.
And then with this section, we're going to add something different once we're done with the skills. Come back and look at this and maybe add some different language or refer to the skills exam for correct administration. Maybe just leave that when we are done with those.
I like that.
Yeah.
So we'll okay, same with this. So I'll just delete all of these and just refer to the skills once, so you don't have to sit there and watch me. Okay, so done with that section. Moving on to this one. The treatment is shock. So all of this goes away, and just the 1 bullet.
Mm-hmm.
Yep. Okay. The pathophysiology, remove bullet 1, add the new one.
And in back, and.
I'm sorry, what?
It should say acute widespread reduction in effective tissue perfusion invokes an imbalance. Take out the D.
Okay. Thank you. So for 3.3,
The
oops,
next
go
one,
ahead.
then, oxygen levels leading, not leasing, to anaerobic metabolism.
You can read faster than me, Julia.
So removing the old bullets and then adding the new. Am I going too fast, Colleen?
No,
Okay.
If due to blood loss, it is called hemorrhagic, not call. Yeah.
Where are you at? I'm sorry.
Yeah, where are
Right
you?
where you are, right there in the line above. If due to blood loss, it is called. Sorry.
keep going down. Right.
Yeah, right there. Right there.
In the parentheses, it says usually defines. It should say usually defined as more than 15% of your body's blood volume.
Good?
Looks good to me.
Okay. So with this one, basically it was exactly the same except the green is new with this. So I didn't delete and then, because there was only a little bit that was added.
Looks good.
Okay, we'll move on. So taking everything out on this one and then adding
It should, under uncompensated, it should say swelling in the feet and ankles.
okay. Oh, there's a lot.
It
Go
It
ahead, I'm
should-
sorry.
Under irreversible absence, absent or difficulty palpating radial pulse.
redial. Redial. And white or pink frothy sputum.
Okay. Okay. So deleting the old, adding the new. Now there was a question mark behind this, so I didn't know. If there should be a question mark behind it.
I don't think so.
And with Holly not being here, so I'll just delete it and that's okay.
Yeah.
Okay.
Mm-hmm.
So, define a primary survey and explain its three components. Since primary survey is listed in 3.6, does it still need to be, does there still need to be a 3.7?
Can we maybe change 3.6 to say like, describe how to assess a patient for shock using primary and secondary survey or something?
I like that.
Is that what you stated?
Yes.
Okay. And so what did you want to do with 3.7?
Now we can just delete it.
Now we can.
Yep.
Okay. Going to, let's see, 311. So, oh, this is supposed to be. Okay, 3.14, deleting the old, adding the new. Okay. Is everyone good with 4.1?
Mm-hmm.
Yes.
Mhm.
Thanks for doing all those details, Desi. That looks great.
4.2. There's more.
Mm-hmm.
Is there something like storage? I don't know. Is this just for IV fluids? Yeah.
So are we still like under the treatment of shock and talking about IV fluids here?
I
We're
think
under
so.
This is the whole new section.
Oh,
we're
no.
under IV therapy.
About IVs. We're in
Yeah.
the IV section now.
Totally new IV therapy. Okay, great.
So good, everybody good with 4.2, moving on?
Mhm.
Okay, 4.3.
Mhm.
Okay. 4.4.
For GBS prophylactic antibiotics, not GBG.
And 4 should be gone, right?
Yes.
There's a lot with that one.
Yours are so detailed, Desi. We're gonna look at my GBS ones and we're gonna be like, let's just copy and paste Desi's.
I'm overcompensating because I don't know what I'm doing.
Under step, can we change it to with needle bevel pointing up?
I'm
instead
sorry,
of
what?
needle angle?
Where are
Under
you at?
step.
Step.
Let's see. Let me. I think you're past me. Hold on. I was still on IV administration of fluids. With the needle bevel pointing up.
Oh, stop.
Oh, yep, under steps. Yeah, go down a little bit further. A little bit further. A little bit further, I think. Yeah,
Right
it
here.
says the needle angle, change it to bevel with the needle bevel pointing up.
Okay.
And then I would add after watch for a flash indicating you are in a vein to advance it a tiny bit further before advancing the catheter to ensure that the catheter is all the way in the vein.
Probably we don't want to put tiny because that's not fair.
Okay.
Right.
Yeah.
I'm like, right, silly Millie in here, but
Advance a bit further or advance further.
1
Let's say-
milliliter or 1 millimeter.
yeah. So watch for a flash indicating you're in a vein, comma, and advance then advance 1 millimeter further.
I'm sorry, will you say that again?
Watch for a flash indicating you are in a vein, comma, then advance 1 millimeter further. Great.
Okay. Good to move on.
Yes.
What tamp the vein, is that a word or is it supposed to be tamponade?
It's supposed to be tamponade.
Yeah.
It's tamponade.
Okay. Everybody good with that one? 4.5?
Mm-hmm.
Okay. 4.6. Everybody good with 4.6?
Mhm.
You want me to hold off, Catherine, and before I move forward?
Just reading through it, but it looks good so far. I think it's fine.
Okay.
Just once the fluid has finished infusing, blah, 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 clean the end of the extension set, not faux.
I'm sorry, what?
So it says discontinue the IV tubing, clean the end of.
Good catch right there at the end. Okay, so 4.7. 4.8. I'm sorry, what? Moving on to 4.9.
Back to 4.7 is, I don't know, it's redundancy to say a 15 drop macro drip set. I don't know, it's picky, but it's just redundant.
What would you like me to remove?
it can either just say a 15 drop set or macro drip set.
Oh, I see. Mhm.
What would you like me to change?
I would leave 15 drop set.
Take out using macro?
Yes, that's just redundant. It's picky, I know.
No, no, it's good to.
The less words, the better.
Okay, going down to 49.
What is it? What is this?
This one is
Section?
identify.
Oh, uh-huh.
Infiltration. Bruise,
The very
hematoma.
The very first sign is failure for fluid to flow.
Mhm.
Yeah.
Did I need to change something?
Well, the very first thing you recognize is that it's just not flowing. You see no drips in the drip set.
Mhm.
Then you're going to recognize
All these other things.
Yeah.
swelling, pain, right? Oh, there it is, lack of fluid flow. It's further down.
Mhm.
Should it be up to, further on the list?
It's the very first thing, right?
Everybody good to move on past that one?
Mhm. And then we want to remove that again, the person being evaluated thing.
Mhm. Yeah.
Well, and this doesn't make sense. If we're listing the dangers of inappropriate placed or maintained IV, site selection, preparation, patency, none of that goes
That's
there.
not the answer.
No, that's right.
Should I work with somebody and get this information in here? I'm not quite sure where that came from. So this
I
whole
think I
thing,
did, but I think I provided, but it is, yeah, it shouldn't say IV site selection, IV site preparation.
Yeah, it seems more like this would be like, you know,
Yeah,
well, yeah.
preparation stuff, that's right. So.
do you want to change it up, Greg, and resend it to me?
Absolutely.
It should be more
Oh.
like infection, bruising, pain.
Mhm.
I was thinking more like something for GBS prophylaxis shouldn't be placed in the AC because of being able to need to move around easily in labor and, you know, making sure that you're paying attention to when the IV bag is getting empty and turning it off in time, or keeping the bag line full if you're going to touch another bag, those kinds of things.
But this says dangers of an inappropriately placed. I mean, I guess in the case of GBS in an AC, that is an inappropriate placement. But I'm kind of wondering if they're one in the same.
Confusing to me. I didn't know what exactly we were looking for. List dangers of inappropriate placed IV, because then the untoward effects of a poorly placed IV I've got listed down below in 4.11: infiltration,
Right.
hematoma, air embolism, phlebitis.
Uh-huh. Right.
It kind of seems redundant. Like almost we could just use 411.
Yes.
Mhm.
Did I miss any in that list right there of untoward effects of a inappropriately placed IV?
Well, and then the medication not being delivered, that's kind of a problem.
Yep.
So we're gonna delete 4.10 regarding the dangers and just leave the risks. And that list is okay?
Well, I would.
Well,
Go ahead, Greg.
Failure to administer the medication. That was a good point.
Yeah.
So it needs to be added to this list?
Yes. It's the number one.
Uh-huh.
How is that a risk?
I know. So now I want to reconsider this title, because I do think that we can merge the two points here. But I'm not. Now I want to reconsider that title.
And that's like a risk of an inappropriately placed IV. Colleen, is that right? What you're saying?
Yeah, that's kind of what I'm saying. Like,
Yeah.
mhm.
But some of, yeah. Okay. Extra. I guess that's also what extravascular medication administration means, but.
Mhm.
Well,
So are we-
yes, extravascular. Whoops, I'm getting reverb on my phone here. No, I think we still need to put in the fact that the medication wasn't administered through the intended route, because you have a real problem on your hands if you've administered a medication that goes in intravascularly. Now, the question is, do I reestablish an IV and give the appropriate dose? Would that be overdosing the patient if there's absorption extravascularly, or does that make sense?
Yeah. Seems fine to me.
Are we good with this new language and the adding of the failure to administer medication through intended route?
Mhm.
And still deleting 10, but adding and adjusting. Okay. Perfect. Okay, same thing with this. I'll be deleting all those. Okay, moving down, same thing. Here we go. Explain basic female pelvic floor and general anatomy.
I thought this looked good.
It was hard to know what was too much and what was, like I wanted to keep it simple, but then you would use one, piece of anatomy to describe the placement of another, and then you'd have to add that. So Holly and I went back and forth on this a bit.
Very detailed. Okay, then we'll just move on. Oh, this was at the bottom. And is this supposed to go to 5 point?
This was actually something that Holly and I, through like this discussion, wanted to add. So basically, when you're considering suturing, like what are things that we need to evaluate for that would interfere? And yeah, it probably needs its own section, or if you guys want it there, I don't know.
Well, I mean, we could put it under steps to evaluate pelvic floor and genital area for damage following birth, because it doesn't necessarily say laceration, and these things are damage. So we could put it under 5.3, no, 5.4. Well, I guess 5.4 is steps, so it's not really what you're looking for. We could make 5.3 define types and degrees of genital damage, and then list these things in conjunction with 1st through 4th degree lacerations.
I don't know. I kind of like having just the degrees as its own item. It seems fine to me to just add another item if you want it in there.
Yeah, just something like additional things to assess for. That's probably not the correct wording, but.
I mean, I think the wording that's in there is fine.
Oops.
And then I did leave a question in there about if these were things we would notice this early in postpartum, like cystocele and rectocele, may not be noted at the time of suturing, and I wasn't sure if that was appropriate there.
I don't know the answer to that question, does he? I've never seen a cystocele or rectocele right in the immediate postpartum that would have gotten in the way of suturing, but that doesn't mean it couldn't happen.
Yeah, that's kind of where I was at. Like, do we leave it?
I don't know.
Or
Because I think that the cystocele and a rectocele is going to be the consequence of a not, you know, that of a repair that didn't take or something that wasn't, you know, that kind of readhesed, and that would be a later downstream diagnosis. Like that's what we're trying to fix and prevent, not notice that. But that's just how I think of it.
So should these, the rectocele and the cytocele need to come out? Is that what you're saying?
I think so. I don't think they quite fit there.
I agree, Desi.
So making it the new 5.4 when performing, leaving the language as is, putting that list minus those two things. And then one of the things with this symphysis, the pubis symphysis, it came up on spell check and I changed it and I don't know if I'm spelling it correct.
It should actually be pubis symphysis separation, I believe.
It's SYMPHYSIS. No A.
All right, so we're not going to have that now. Okay.
And I don't know how much the pubis symphysis separation would interfere with suturing, but it probably would change the way that I approach the situation.
Sure, and how you position her.
Mhm.
Okay, so moving on to, oops. I'm having a lot of backbeat here, sorry guys. Okay, 5.4. No, there were question marks again, so.
Except to evaluate pelvic floor. Why not the first three?
I don't know. So should those be left on? Because I wasn't sure if I should delete those.
I'm not sure. Anything you see in here that are changes are probably like my disastrous attempt to do this way too late at night. So good luck, everybody. Feel free to just destroy it and start over.
We have more time to look at this document too, because what I'm going to do is I'll go back and I'll clean it completely up and then send it to you guys again. And so you'll get a clean read and it'll be much easier to look at.
Mm-hmm.
So everybody okay with leaving everything in that 5.4?
I feel like there should be a visual assessment listed there. Well, I guess maybe that is observation.
But you
Should
could
it say
clarify it and say visual.
anything else we need to add or delete?
Does it matter? Like, I want to say internal assessment rather than internally assess.
Yeah.
Does anyone else feel that way?
Totally.
Fine.
consider internal,
Rectal exam. Like a digital exam.
I'm sorry, what?
Like a digital rectal exam.
Digital?
Yep, like with your finger.
Okay.
And then do we need to say perform external? Could it just be external rectal exam?
Totally.
It,
Just get rid of
Yeah.
perform. Desi's right. Be consistent.
okay.
And then when it just says consider internal digital rectal exam. No, the wording was fine. I'm just wondering if that needs more details. And maybe this is just me being an overthinker. Like, should we list when we should consider that, or?
I know that was a hard one because, you know, some recommendations are that you do it every single time, and some providers do, and a lot of us do it only when we feel like the tear is, you know, warrants that, or based on what we're seeing. So I'm not sure.
Yeah, I'm not sure either. I mean, I certainly don't do it every time.
No.
So just leaving it, consider it, and move forward.
Yeah, let's for
Okay,
now.
yeah.
Okay.
Just go right back up, Cynthia. Perennial, not perennial.
Oops, that was
Yeah.
right. Hang on.
I like that. Clearly, I would rather be in my garden.
Oh, I can't even spell it. So
Yeah. Perennial. Just one N. There you go.
yeah, I'd rather be in the garden as well, Colleen. Okay, so 5.5, identify circumstances when require repair, and then the answer is, and do these need to come off?
Oh, I guess no trauma identified is like, oh, that seemed like low hanging fruit, like no brainer, but yeah, probably should be in there.
Well, it says identify circumstances where perineal damage may not require repair. So if there's no damage, like,
Then there's
Yeah.
no trauma. Yay.
So take it back out.
Mm-hmm.
And so good to go with the 3 new and taking the 3 old out.
sounds fine to me.
Yeah, I mean, the first two, hemostasis and structures approximate, and then the second one, first degree lacerations with hemostasis and approximation, seem a little bit redundant.
That's true.
It seems like,
Yeah,
Yeah.
yeah.
So we'll take out, leave the new in.
Well, I would ditch maybe what do you think, Catherine? Like just leave out.
I mean, you could just delete the first one and say lacerations with approximation and hemostasis, and delete first degree.
Hmm.
Some people would think differently, but I don't know.
Mm-hmm. I like that.
No, I think that, yeah, I like that too.
So just cross out first degree.
Mm-hmm.
And then take away the whole bullet point above that.
First, I see. Okay. So take out first degree.
Mm-hmm.
Sorry, had to find where I was at, and take out this.
Yeah,
Yes.
exactly.
And then we're gonna So are we gonna leave those three then? Or take
No.
those out and only have these
They're
two?
just 2 bullets. Yeah.
Okay, perfect.
So what is the identify circumstances when perennial damage may not require repair? So do you also want to put out there when the person declines, refuses? Is that part of, I mean, that would be a circumstance where I wouldn't do it, or I
Right.
guess it would require repair, but okay, never mind, think out loud.
That occurred to me too, but yeah, I think it's
Yeah.
fine.
I was having the same thought process, but yeah, I think this is appropriate.
Okay. 5.6, is this one okay?
Mm-hmm.
Okay, and so 5.7, explain the consequences of
I
body damage.
actually would like to add some additional things to the types of perineal damage. So we were just looking at that. Go back up.
Oops.
So right there. So another thing that's come to my attention just in practice with other midwives is urethral repairs or tears that are
No, 5.6.
5.6.
Oops, sorry.
yeah 5.6. And I don't know, I don't think it's in our laws currently, but things that are next to the urethra or might involve it really should be consider transferring for a repair. I don't know if you guys have thoughts on that. I've seen it once where we've gone in to do that because it was such a delicate area. So
I'm also just thinking on the title of 5.6, it maybe should just say which require transfer of care, because that's what the law is. Referrals seems a little vague.
Mm-hmm.
yeah. And do we want to include that here, or should it be a consideration?
Yeah, that's a tough call because we're using the language requires.
Right.
So while it certainly makes sense, it's not required by OAR.
Mm-hmm.
Should we have maybe a new 5.7? So the required versus the, however else you wanted to state it.
To consider, like
Yeah. You could have
and-
list the types of perineal damage outside our scope for repair, and then list types of perineal damage to consider transfer. Because I also, like, when I teach this class, I also usually touch on like taking your skill and experience into account. So like if you are, if it's a repair that is second degree, but it's more complicated and you don't feel confident or competent in doing it, I recommend that they call another midwife or like, figure something out, right? So we could list that too with like their urethral repairs that aren't required to transfer, but is wise to consider.
yeah, and these are things that like I didn't know about until like in practice or assisting other midwives that had a lot more experience, and then I'd be surprised. I'm like, why are they transferring? But it really makes sense when it's particular areas like the urethra.
Mm-hmm.
And not things that I learned in school or through testing.
So which requires transfer of care, which may require, or may.
Or should be considered.
Should be considered for transfer of care.
Yeah. Mm-hmm. And so then would you put there, Julia, would you also have another bullet point in 5.7 that would say something about within the skill level, the skill set of the midwife?
Yes. Uh-huh. We could say like any laceration outside of the skill set of the midwife or something.
Yeah.
Mhm.
There's that perennial again.
Right, in 5.7. Cerinthia and I need to go garden. That's what that's all about.
PERI, yeah. There you go.
Oh, goodness. Okay, so I'm not sure where this comment came from, but it was that injections of peri do not go here.
Yeah, what is that? That was me. I'm like, what? If we're talking about the consequences of a poorly done repair,
Infections?
maybe it was infection.
Oh, infections of the parent.
That's what it probably was.
Uh-huh. Yeah, we have infection on that new list anyways.
So it's okay to delete the old and add the new?
Yeah, it looks like they're all on there.
Okay. There was a comment in regards to not sure for infants.
No, it's just, well, that they're not safe for infants.
Okay. So what do we need to do with that?
I don't think it's, I mean, it's not entirely pertinent. I was just gathering all of the information. This ain't my wheelhouse, man. I was just gathering all the information about the different, classifications of anesthetics, and that is true. Not that we would ever be administering it to an infant, but because of the hepatotoxicity, you wouldn't use it for an infant, since we try to be somewhat thorough about what these medications are. I just thought that I'd throw it in there. I don't really care if it lives there or not.
It seems like some of the stuff on here though, like I don't know, like maybe the onset and duration maybe is a pro and con of one type versus the other, which isn't listed here.
Mm-hmm.
So leaving those two and all of the ones in green, and okay to take out the first two and the one after duration.
Well, actually, I mean, I think I wasn't really paying attention to what I was doing. You're right, Catherine. And then maybe even the topical availability is a pro of lidocaine.
Uh-huh.
So should that?
Me like maybe we could consider doing this as like a pro and con list, but I don't know if we have to get that detailed.
Separating them out.
I'm having trouble understanding this section, so I don't know.
Clearly I was too. So I think looking at it now, I'm realizing that maybe we back up to this header and decide what are we looking for here. So we're saying pros and cons of the local anesthetics. Do we need to, so then we want like a pros for each type, or?
Yeah, I was kind of thinking it should be like a pro, like, one subsection that's amides and one subsection that's esters, and then under each would be a pro and con list.
A con list, yep.
Yeah, I like that.
Much cleaner.
Mm-hmm.
I'm happy to do some research about that and get back to you, Cerinthia, if that would be helpful.
Yeah, that would be great. So I'll do ester and amide, and then pros and cons. Same with this.
Mm-hmm.
Okay. And Okay.
Should we do the same for that 5.9? Unless we want to change the wording to explain the benefits. But if we're going to do pros and cons, it should be,
In list form again.
yeah.
Do you want it a list form or do you want the benefits?
Well, then you would have to do benefits and drawbacks.
When you go
benefits and cons.
I'm sorry, what?
Are there cons listed below? Like,
No, that's it.
well, I'm confused about this because we don't use anesthetic that has epinephrine in it.
Right.
So it's not even benefits, it's it would be drawbacks.
Well, I mean, these are positive things listed
Are
here.
they? Oh, okay.
So do we want to list the cons and do we want to list the cons of this? Or do we want to redo how it reads? So
Or
do we want to, go ahead.
Or do we, I mean, do we need it at all? I guess probably we do.
Yeah. So should we write the benefits then?
Let me take a look at this one. I'll look up the cons and get back to you because I'm not remembering it correctly right now, but I know there's
Right.
a
There are
reason.
cons, yeah. I mean, some people are allergic to epinephrine.
Yeah.
And some people just have a strong reaction. It can create anxiety and rapid heart rate. Like I refuse the dentist. I won't get it.
Right. Anxiety. Yeah.
Okay. So we can move on and then we'll work to, go ahead.
And that, well, it'll match the one above it better.
Yeah.
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 Pros list and cons list. Yeah.
Okay.
Good.
Nerve is spelled wrong there. Intraperineal, labial, and vulval tissue. Yeah. For the purpose of, it says nerve, it should be nerve.
Block. I mean, and we also have topical.
Yeah.
Mhm.
List, topical anesthetic prior to infiltration.
Am I missing something?
We should add another bullet point
Add another
that's
bullet.
topical. But the first bullet point should also say, oh, it says via injection. I guess maybe it should be IM. I don't know. I guess sometimes it doesn't always.
It's not always going into a muscle.
It's going to. It's fine. It says via injection, so that's fine.
Should this say something other than topical?
No, that's right.
Yeah, topical application prior to infiltration. Anesthesia.
Prior to prior to what?
Infiltration.
So this was I wasn't sure if I needed to delete these. Let's see if there's anything else.
Mm-hmm.
Yes.
No.
You need sterile drapes and gloves and a needle driver. Yeah, I didn't necessarily intend for them to be deleted, but more potentially just added to.
Okay.
And in 5.11, it says the equipment needed to effectively repair first, second, and third degree labial lacerations. So we can't repair third degree lacerations, and so it should say like repair first and second degree and labial laceration, probably.
Mhm.
So first and second degree,
And
yeah.
labial.
Mm-hmm.
And then I took, I'll delete the second suture.
Oh, sure.
I think gauge is supposed to say gauze.
Thank you.
Oops.
And toothed pickups is listed twice. I think we should delete the first one and just change it to tissue forceps.
Mm-hmm.
And then
Oh, I see what you're saying. Sorry.
the first green one we can delete. Yeah, either way.
And I've never heard it described as a needle driver. Isn't it usually, or like needle forceps?
Needle
Right.
driver is pretty common.
Needle.
Yeah, needle. I've used needle driver, but I don't know that it matters.
Okay.
So that section looks really incomplete.
5.1.
5.12.
Yeah.
Yeah, I think we should do like the 2-column, like
Mhm.
we did the pros and cons, like a column for synthetic and a column for organic.
5.12. I'm happy to add that to my list to send info about.
Catherine, you're gonna do my whole job for me. I think I gave up right about here. It's like it is 1 o'clock in the morning, and I am going to.
Okay.
So that just needs flushed out as well.
So on this list, it just needs to have the appropriate use of each one.
Mm-hmm. Yeah, I can do that.
Okay.
Mm-hmm. 514 looks good to me.
Hold on,
Didn't
5-1. Oh, go ahead.
well 515 is a repeat of above.
Mhm.
Why does the list look different? So
Because it has some different names of different things, but
Mhm.
oh,
So-
and look, there's the
Okay.
answer to the other one.
Oh yeah. Sweet.
So this could go back up.
No,
Well,
so
just
just
the suture or the
the-
needle.
suture types is the answer to the one that Colleen was going to give you the info before. Not those first two, but just the bottom 4 right there.
These four right here?
Yeah.
Okay, so that's on your list, Colleen, or do you just want me to move it now?
Not anymore. I think it looks great. Well, well, actually it's not complete though, because right there, this is all CT1 needle for, this is more about the suture type and not the needle type.
Well, go back down, Cynthia. So can you move those bottom four up to the other one and let's look at it up there and then come back to this one? Yeah,
Right
so
there.
right in here. I mean, I think it's saying the most appropriate use of each. So the third one down, 40SH, it says for skin sutures. So I mean, you could add that under SH, but I also use SH for labial tears sometimes.
Right.
Oh, so it should be for skin sutures and,
Yeah, sure. And then it's just saying, it's saying a 3.0 versus a 4.0 or 2.0 of a CT1 needle for these different things, but I think you could use a CT2 or 3 for any of those things also, depending on the size of the tear. You know, it's like,
Right, the size and the location.
so I can put these on not 1, but 2 and 3. And this one, is that what you're saying here?
I can't imagine using a CT3 for perennial muscle sutures.
I've never used the CT3 at all, but
Either.
I only have 1 and 2.
I'll sometimes use it for like a labial or like a periurethral tear.
Okay.
So do you want to still work on this, Colleen? And then now you have some info to go on?
Yeah.
Okay.
Great.
Perfect.
And then we can figure out the one further down.
So
Okay.
were we going to just delete 515?
It's
Feels like, yeah, it feels like overkill. We already listed these things.
redundant, yeah.
I would.
Yeah, the only thing I thought, and I guess this doesn't matter, is that it only says 1% lidocaine in here, and some people use 2. I don't know.
Mhm.
It says that lower down.
Oh, it does.
Yeah. On the list above, we just said lidocaine. So.
Okay.
So do I need to move anything from this list anywhere else? And we're going to delete 515.
Well, I
Yeah.
mean, there are a couple things on this list that we didn't have listed above, which are 10 mil syringe, 22 gauge needle. I think maybe that's it. Alice.
Yeah.
And
We don't have syringe and needle.
Yeah.
So do we need to add that to 5.14
No,
Mhm.
go up there.
5.1.
up here?
5.11.
Oh, 1, I'm sorry.
Right
Yeah.
here.
Mm.
And probably instead of lidocaine, we should say anesthetic.
Yeah.
Actually, just delete that whole.
That sentence, because we have
Yeah.
lidocaine listed, the last green one. So change that lidocaine to anesthetic.
Okay, I see what you're saying.
Great.
Okay.
And then make
And
515, I think.
will all be gone. Okay, I don't need to do that. Okay, 516.
Inverting skin edge. I'm a little bit confused about this question and if we're answering what it's asking about. Is it just asking about like how to do a tie?
Yeah.
Mm-hmm.
I mean,
Right, so either you just dish it about the instrument tie, because it's like demonstrate the correct use of a needle holder is more what it's talking about, but is that what we really want to be answering? I'm not sure.
right. Or is it,
Right,
Is it
because this is
about
all
needle
about eyes.
I mean,
I
it seems like
wonder-
it's saying we're not supposed to do ties with our hands. Show us how to do a tie with a needle holder, which is a skill.
But we do
Julia,
al-
I'm sorry,
I-
you had something to say, Julia?
I said we do also require them to demonstrate hand ties.
You do?
Really?
It's part of
Really?
the curriculum. They have to demonstrate a hand tie and an instrument tie.
Wow, I've had my hand slapped for doing that.
Yeah, I mean, I rarely encounter anyone who does hand ties, and I give them like
Meeting somebody right now.
big
I'm old.
old.
So
Yeah.
do we need to add the hand tie in here?
No, it's further down already.
Oh, it is already there, okay.
Uh,
I think
Well,
we just need to
pros
change
and
the answer here.
yeah. But I wonder if what we should do is, since we're asking them to demonstrate the thing, is once we have the skills test
Yeah, exactly.
lined
This should
up,
come
just
from the
copy
skill.
and paste it there.
I think so too, Julia.
So we'll do like we did before.
Refer to
and
skills exam.
refer. Okay. Do we want to have on 5.17 the pros and cons separated like we do?
Yeah, I think
What
a
are the cons?
2-column list is a good idea. For both hand ties and instrument ties.
Does somebody want to work with me on that? Oopsie.
Not me.
Julia? Desi? Anyone? Greg?
I can do that. Which one is it? What's the number here? 5, 1, 7, and 1, 8. Okay.
Yes. Uh-oh.
I'll make up for missing last time. You guys did work.
The phone just said something was going on with that. And so April's gonna have to fix this real quick, but at this point, you guys, if we could take a 15-minute break.
Okay.
Oh, but we're so close.
Are we? Is there- Well, my bladder won't hold for another 15 minutes. So unfortunately, we're gonna have to take a 15-minute break, guys.
Okay.
Thank you. I'll see you in 15 minutes.